Hello and welcome to our new topic. Today's topic is about a group of commonly prescribed drugs that are used to treat congestive cardiac failure, or congestive heart failure. They do it through various mechanisms and their rational use requires underlying pharmacological knowledge. In this lecture, our main focus will be on those drugs which support cardiac contractile effort or have positive inotropic effect. Because many other drugs listed here have been discussed under other lectures, such drug treatment of hypertension, we would avoid duplication. So, let's start. The learning objectives are shown. Please take a look. In the pathophysiology of cardiac failure, decreased cardiac output and increased pulmonary capillary wedge pressure are central concepts. A reduction in cardiac output activates the renin-angiotensin-aldosterone system, RAAS, in the sympathetic nervous system, leading to increased heart rate, afterload, and preload in an attempt to restore cardiac output. In short term, this response saves life. However, this neurohumoral axis becomes deleterious in the long run to the extent that these compensatory mechanisms may even cause myocardial ischemia, further worsening left ventricular function. Ejection fraction, EF, is a common measure of cardiac output and determines therapeutic efficacy in patients of heart failure. We may divide heart failure into two, on the basis of ejection fraction. One, with reduced EF and the other with preserved EF. The former type shows a better prognosis than the latter. Reduced cardiac output produces the characteristic symptoms of cardiac failure, such as pulmonary and peripheral edema. The main therapeutic goals include relieving symptoms and preventing complications, as well as improving functional capacity, ultimately increasing survival. Since various cardiovascular disorders share pathophysiological processes, no wonder that a drug group can be used in all of those on this basis. For example, the drugs used to treat chronic hypertension, such as diuretics, angiotensin inhibitors, and vasodilators used in acute hypertension as well as ischemic attacks, can also be used to treat congestive heart failure. For example, diuretics used for symptomatic relief effectively reduce sodium and water retention, thereby decreasing plasma volume and venous congestion. They also improve dyspnea and peripheral edema but do not directly improve survival. Drugs inhibiting renin-angiotensin-aldosterone system at different levels, already discussed with antihypertensive drugs, are very important to reduce preload and afterload. They also help correct the deleterious neurohumoral axis. Some beta-adrenoceptor blockers, including metoprolol, bisoprolol and carvedilol, have also shown therapeutic benefit. The unique group of drugs which we should focus in this lecture is the inotropic agents, used to enhance contractility when cardiac output is critically reduced. This group includes some beta-adrenoreceptor agonists, phosphodiesterase inhibitors and digitalis glycoside digoxin. This slide classifies the drugs which have positive inotropic effect on heart and are discussed in the following slides one by one. Beta-1 adrenergic receptors are primarily responsible for carrying out the sympathetic control on cardiac force and rate of contraction. Hence, they are useful to stimulate a failing heart. For this purpose, either dobutamine or dopamine are commonly used. They differ in their characteristics and utility as given in the next slide. This slide shows important differences between both dopamine and dobutamine. Take a closer look and compare both. Dopamine acts on alpha, beta and D receptors of catecholamine, while dobutamine is a beta-1 agonist. Since visceral circulation, especially renal blood flow, depends on D receptors, it becomes a logical choice if CCF is accompanied by circulatory shock or renal failure. Note that aspect carefully. Beta-adrenoceptors, through intracellularly coupled adenylyl cyclase enzyme, generate cyclic AMP for various physiological effects. This cyclic AMP is degraded by another enzyme called phosphodiesterase. Blocking phosphodiesterase would result in increased intracellular cyclic AMP and stronger physiological effects, such as increased force of cardiac contraction as well as tachycardia. Amrinone, milrinone and aminophylline are such drugs which can inhibit phosphodiesterase. Their utility is in acute decompensated heart failure. Amrinone inhibits phosphodiesterase 3 in myocardial cells and increases the cyclic AMP concentration. It also increases intramyocytic calcium release. Both these effects increase cardiac force of contraction but also predispose to arrhythmia in the long run. Amrinone also produces vasodilation that also helps support deteriorating cardiac output, like any drug that reduces preload or afterload. It is used only in short-term management of acute decompensated heart failure. Milrinone, which is a more potent derivative of amrinone, with fewer side effects. As continuation, let's also discuss some other drugs which produce marked vasodilation and are useful as adjuncts in management of acute congestive cardiac failure. One of them is nasiritide, a BNP analog. An additional effect of nasiritide is diuresis due to its effect on BNP receptors. Because of short half-life and serious adverse effects, it is reserved for acute heart failure treatment only. Naproxen is a natural inhibitor of various vasoactive peptides, including ANP, BNP, and bradykinin. Sacubitril is an inhibitor of naproxen and is only used with valsartan as ARNI or angiotensin receptor naproxen inhibitor. Side effects similar to angiotensin inhibitors, such as angioedema and hypotension. While use of beta-adrenoceptor stimulants for the treatment of CHF is easy to comprehend, some beta-adrenoceptor inhibitors also show a beneficial effect in CHF after chronic use. So far, the evidence exists for bisoprolol, metoprolol, nebivolol and carvedilol. This is in contrast with the general side effect of beta blockers to actually cause acute heart failure due to their inhibitory effect on myocardial contraction and conduction of electric impulse. Although it is not fully understood why some beta blockers could be beneficial in CHF, but suggested mechanisms include attenuation of the adverse effects of high concentrations of circulatory catecholamines in CHF, upregulation of beta receptors, decreased heart rate that allows better heart filling, and reduced remodeling through inhibition of the mitogenic activity of catecholamines. Common characteristic of such beta blockers includes a lack of intrinsic sympathomimetic activity or partial agonist activity. In addition, L-enantiomer of nebivolol is responsible for its unique vasodilatory effect by activating beta-3 adrenoceptors to increase nitric oxide, NO, production. Thanks for watching. Don't forget to like, subscribe, and share. Happy learning!